Good evening, everyone, and welcome to Echo for PWS. We appreciate you joining us, and my name is Lynn Garrick, and I'm the Medical and Research Coordinator for PWSA USA. Many of you have participated in Echo sessions before and are familiar with the concept. For those of you who are not, I'd like to briefly share the background on Project Echo. So I am going to share my screen here, if I will allow that, and slideshow. Oops, there we go. So this is our cardiac concern. So Project ECHO stands for Extension for Community Healthcare Outcomes, and it was established in the University of New Mexico in 2003. Using video conferencing technology software, Project ECHO connects providers in underserved communities with specialists and experts for long-term telementoring, collaboration, and case-based learning on urgent health conditions. Today, people and organizations from all over the world leverage this ECHO model to scale their own social initiatives in health and other fields like education and social justice. ECHO partners in 40 countries and operates more than 860 ECHO networks, which have trained more than 140,000 professionals eager to learn best practices in their field. So there's a few guiding principles. ECHO's guiding principles are A, for amplification and the use of technology to leverage scarce resources. The B is share best practice to reduce healthcare disparities. 3, apply case-based learning to master complexity. 4, evaluate and monitor outcomes using web-based database. And the most common ECHO phrases that you will hear is moving knowledge instead of patience, and all teach, all learn. And without further ado, this is Dr. Loker, who has been a pediatric cardiologist for over 25 years. He enjoys all aspects of pediatric cardiology, but is particularly interested in Kawasaki disease and children with special needs. His daughter, Anna, with Prader-Willi syndrome, has shaped his life and practice. Along with his wife, they have been active in Prader-Willi syndrome on both the state and national level. He is a member of the Clinical and Scientific Advisory Board for Prader-Willi Syndrome USA and has contributed to multiple medical publications on Prader-Willi syndrome and helped organize the medical alerts booklet. He is a member of the state committees on sudden death in the young and newborn screening for congenital heart disease. Dr. Loker sits on the National Advisory Board for Congenital Heart Program at the University of Michigan. He enjoys going on medical mission trips to Africa to treat congenital heart disease, and in his free time, he enjoys boating and scuba diving. And with that, here's Dr. Loker.
Thank you. Let me go ahead and share my screen. We can go on. There we go. So I hope everybody can see this. This is going to be on the cardiac complications in Prader-Willi syndrome. I have no disclosures and no conflicts of interest. If we look at the causes of death in both the United States as well in France, about 15% of deaths in Prader-Willi syndrome are attributed to a cardiac etiology. What's interesting is that in the United States, the average age is actually about 14 years for the mean age of death. They did not give that, at least in the French study. What I'm going to be talking about is different areas of topics, including metabolic syndrome, coronary disease, congenital heart disease, cardiomyopathy, pulmonary hypertension, and right heart failure, the autonomic nervous system, and the effects of growth hormone. But I will not be discussing thrombotic risks in Prader-Willi syndrome. My feeling is that that is a completely it's a separate topic tied to the cardiac, but that probably deserves its own ECHO program. If we look at metabolic syndrome consists of central obesity, impaired glucose tolerance test, diabetes, hypertension, high triglycerides, low HDL, and it dramatically increases the risks of coronary artery disease. Most studies, you have to have at least 3 of those to make a diagnosis of metabolic syndrome. There's a 2009 Italian paper of 109 Prader-Willi patients versus with 96 normal obese, all between the 2 to 18 years of age, 50 obese Prader-Willi syndrome, and 59 obese Prader-Willi syndrome. What's interesting in this paper that if you look, about 12% of the non-obese Prader-Willi patients had hypertension, but obese Prader-Willi is very similar to the control obese, non-Prader-Willi obese. Same thing with low HDL, high triglycerides, and impaired glucose tolerance tests. The non-obese Prader-Willi syndrome had a much lower risk and the obese Prader-Willi syndrome was very similar to a obese control. Type 2 diabetes was only found in 4 obese children with Prader-Willi syndrome, and to get that metabolic syndrome score over 3, there is 0 non-obese Prader-Willi versus 8 obese Prader-Willi and 15 controls. So in their study, they did not see there was a significantly increased risk of metabolic syndrome in the obese Prader-Willi versus obese controls. However, as in a lot of studies, a lot of research, you get differing data. In a 2022 study, they did see a significantly higher risk of metabolic syndrome, type 2 diabetes, hypertension, and dyslipidemia in obese Prader-Willi versus obese control, but they also were comparing 68 patients with Prader-Willi syndrome to 204 obese controls, which gives you a type 2 error. So it does make the data a little bit more difficult to interpret. The Prader-Willi patients, of the Prader-Willi patients, those that never had growth hormone therapy had a significantly increased risk of metabolic syndrome, type 2 diabetes, hypertension, and the dyslipidemia than those patients that were either on growth hormone previously or still on growth hormone. So there did seem to be somewhat of a protective effect of growth hormone for metabolic syndrome in the Prader-Willi population in their study. When we look at diabetes, studies have shown that obese individuals with Prader-Willi syndrome can have type 2 diabetes with rates up to 25% in adults, but the incidence was not higher than in BMI matched individuals in the general population. In some cases, it was actually lower. A 2005 study showed that individuals with Prader-Willi syndrome had both lower insulin levels and lower insulin resistance, which would go along with a lower risk of type 2 diabetes in Prader-Willi syndromes than in BMI matched general population, which they theorized might be related to reduced visceral adiposity. A 2014 study showed non-alcohol fatty liver disease, which is a consequence of type 2 diabetes, was less frequent in Prader-Willi women than in age and BMI matched controls. So again, does not seem that there is a higher risk for diabetes in Prader-Willi syndrome than in obese controls. Blood pressure. Obesity can increase the blood pressure due to fat compression of the kidney, increased sympathetic activity, sleep apnea, and increased systemic resistance from the weight. There was a 2020 paper from Netherlands of 115 patients with Prader-Willi syndrome that had an average age of 29 and BMI of 29, so not terribly obese, but they showed 19% had hyperlipidemia, 17% had diabetes, and 18% had hypertension. 2021 Italian study showed higher ambulatory blood pressures in Prader-Willi syndrome compared to obese controls, in particular nighttime blood pressures. This would be consistent with an increased sympathetic stimulation, meaning that they were always somewhat stressed even at night. In terms of lipids, a 2022 paper showed hyperlipidemia in 6% of adult Prader-Willi patients, but several studies have shown that Prader-Willi patients have a similar lipid profile to actually lean controls. This is felt, again, due to the decreased visceral fat than in the general obesity. There was a Chinese study that showed alterations in the gut biome, the bacteria in the gut, can dramatically affect both insulin resistance and lipid levels in Prader-Willi syndrome. And several studies have shown that growth hormone deficiency can also cause elevated lipid levels. When we look at coronary disease, heart attack is the most common cause of death in the United States, accounting for about 18% of all deaths in the United States. All cardiac problems cause for about 15% of deaths in Prader-Willi syndrome. So certainly there doesn't seem to be a higher risk of death in Prader-Willi syndrome from cardiac causes than in the general population. But there is an average age of 15 in Prader-Willi syndrome, whereas if you look at the average age of coronary disease in the United States, is about 65 years in men and 72 in women, and 57 in obese adults. So certainly they seem to have a lower risk, the same risk, but their coronary disease, it occurs at a much younger age. There were only 4 case studies that I could find of coronary disease and Prader-Willi syndrome, all between 26 to 36 years of age, all with morbid obesity and type 2 diabetes. What's interesting that of the 4, only 2 had complaints of chest pain, where the other 2 only complained of leg edema. So they did not have the typical prodrome or the typical findings that you would expect for coronary artery disease. We know that stress can increase the risk of cardiac disease in all groups of the general population. Studies in growth hormone deficient adults also show an increased risk of atherosclerosis. And the question is, could growth hormone deficiency be a factor in the younger age of coronary disease in Prader-Willi syndrome? There may be a selection bias, as there may not be a realization to report on older individuals with Prader-Willi syndrome and coronary disease. Plus, the atypical presentations that we saw may also cause misdiagnosis. There's also a tendency of not obtaining autopsies on individuals with Prader-Willi syndrome that pass away, and then we wouldn't then attribute that death to the Prader-Willi syndrome. Only 8% of the deaths in the United States study had an autopsy, and even fewer in the French study. So the true incidence of coronary disease and cardiac disease may actually be higher, but this is all the information that we have to date. When we look at congenital heart disease, there was really only one paper that really looked at congenital heart disease back in 2012. Tirado looked at, it was a retrospective review of echocardiograms on 180 children in Argentina with Prader-Willi syndrome, and they found that 4.4% had congenital heart disease diagnosed in the first 4 weeks of life. It was equally split between deletion and UPD, but seemed to be more frequent in girls. Of those patients, 5 had ASDs, 1 patient had an ASD and a PDA, 1 patient had a VSD, and 1 patient had pulmonary stenosis. The normal incidence of congenital heart disease in the general population is only about 0.6 to 1%. So certainly the 4% is a significantly higher incidence. But if we look at the risk of ASDs in the general population, it usually accounts for only 10 to 15% of all cases of congenital heart disease, whereas in the Tirado study, it was up to 75%. So a much higher incidence of atrial septal defects. The problem is that when you're looking at infants in the first 4 weeks of life, all babies before they're born have an atrial septal defect. It's called a foramen ovale. Over the first 4 weeks of life, those tend to close off. So a number of those patients, since this was a retrospective review, they didn't have the echocardiograms, they were just relying on what the echo report was. A number of those may have been actually these patent foraminal valleys that just hadn't closed yet. If you look in a 2024 retrospective review of all live births in Copenhagen, they showed that 80% of all infants under 4 weeks of age have an atrial shunt or an ASD. Cardiomyopathy is the next top. And what I'm going to be talking a little bit is the nectin gene. Nectin is a gene in the Prader-Willi locus. Nectin deficiency in mice is associated with decreased cardiomyocyte contractility. What's interesting is nectin is not significantly expressed in cardiac tissue. So the theory is it is due to an interaction of nectin with other proteins, such as the myosin light chain. I only found one case study in the literature describing a patient from Japan that had dilated cardiomyopathy. I was unable to find any case reports on hypertrophic or restrictive cardiomyopathy in Prader-Willi syndrome. One of the ways that we can look at how the heart is reacting is a measurement known as strain. It's basically a measurement on how the LV contracts and relaxes, and tends to be an early predictive of problems with heart muscle, much before we start seeing actual decreases in cardiac function. Changes can be seen in strain with cardiomyopathy, infarction, hypertension, and stress-induced cardiomyopathy. The reason I'm saying that is that a number of studies have looked at abnormal strain rates on echoes on patients with Prader-Willi syndrome. The 2021 study showed elevated hypertension, diabetes, CRP with normal lipids, troponins, BNP, but normal LV size and function, but they did have a decreased longitudinal strain. Same thing with in a 2007 paper on adult patients with growth hormone deficiency, also shown decreased strain rate on echo that normalized after 6 months of growth hormone supplementation. The strain returned to lower values after stopping the growth hormone. Growth hormone and IGF-1 are implicated in cardiac development and function, and growth hormone deficiency can not only decrease the LV mass, it can also decrease the strain, decrease exercise tolerance, and elevate serum lipid levels. Pulmonary hypertension and right heart failure. This is a picture of a patient with Prader-Willi syndrome. So you can see just how much adiposity can affect, how much that fat mass can affect the chest, the ability of that chest to fully expand. In this case, this patient also has some right-sided enlargement. Individuals with Prader-Willi syndrome can have an increased risk of pulmonary hypertension due to either pulmonary emboli, obstructive sleep apnea, central apnea, aspiration, the chemoreceptor response to oxygen and carbon dioxide, scoliosis with restrictive lung disease, and hypoventilation secondary to the decreased muscle mass and obesity. There was a 2024 retrospective review of 239 patients from the Children's Hospital Los Angeles. They found that of their patients, 43 had adequate images, and 18% of them had pulmonary hypertension at an average age of only 10 years of age. They all had BMIs greatly over the 99th percentile, and an apnea-hypopnea index of 8.8, which is significant. This underscores the respiratory risks of younger patients with Prader-Willi syndrome and the development of pulmonary hypertension. A 2017 Danish study in 155 patients, and again, I don't know what the Danish do over there, but they saw no cases of pulmonary hypertension or sleep apnea compared to age and BMI matched controls that had 8 pulmonary hypertension and 7 obstructive sleep apnea. They did find a 10% increased risk of venous thrombosis in Prader-Willi syndrome than in the general population, control of 15,500, which again then gives you a type 2 error with statistics. The autonomic nervous system is kind of interesting in Prader-Willi syndrome. There's been a number of studies, number of papers that have looked at the autonomic nervous system. The autonomic nervous system is composed of both the sympathetic and parasympathetic systems, and several studies have shown increased cardiac morbidity and mortality in the general population that have a higher sympathetic tone. In particular, post-MI, there was a very interesting study in the VA hospital where they found a 56% increased mortality in individuals that had a low R to R variability. That would be if they had a higher sympathetic tone, lower parasympathetic tone, because you're eliminating that parasympathetic variation in that R to R interval with respiration. This then has led to the use of beta blockers in the majority of patients post-MI, which is also frequently used in congestive heart failure because of that higher risk of sudden death because of the higher stress that we can see. There's also been significant interest in autonomic dysfunction in Prader-Willi syndrome. It has been implicated in decreased salivation, increased pain threshold, gastroparesis, hypothermia, and possibly even in obesity. Most clinical studies in Prader-Willi syndrome do show an increased sympathetic or decreased parasympathetic tone in Prader-Willi syndrome, meaning that the individuals with Prader-Willi syndrome are always at stress. They always seem to be stressed from an autonomic standpoint. There was a 2017 paper from Children's Hospital of Orange County showed Prader-Willi syndromes had a delayed heart rate recovery after exercise, consistent with an increased sympathetic activity. A 2023 study showed blunted heart rate increase with head-up tilt in Prader-Willi patients compared to BMI matched controls. A 1996 paper showed decreased R to R variability in 14 patients with Prader-Willi syndrome compared to 14 age and sex matched controls. So again, all of this goes along with individuals with Prader-Willi syndrome seem to have a higher sympathetic or lower parasympathetic tone. What's interesting is that if you look at the autonomic nervous system in growth hormone deficiency, we can see that patients, normal adults that are growth hormone deficient, have an increased sympathetic activity. This was a study, a 2021 Swedish study. These are normal individuals with POTS, postural orthostatic tachycardia syndrome. So these are individuals that have a significantly elevated sympathetic response due to head-up tilt. That is just going from a lying position to a standing position. They get a significantly increased heart rate response, going along with this increased sympathetic activity. And what you can see in their study is that the majority of individuals that had lower growth hormone deficient, that had POTS, had lower growth hormone levels. 19 effects of growth hormone deficiency. There was a classic study back in 1990 that looked at individuals with hypopituitarism, which can also cause decreased growth hormone levels. They showed that there was a twofold increase in mortality for cardiovascular disease in those individuals that had hypopituitarism. And it was all due to vascular disease. Left LV mass, wall thickness, and function have also been shown to be decreased in growth hormone deficiency, similar to other studies in Prader-Willi syndrome. One study showed growth hormone deficiency caused systolic and diastolic abnormalities in 45 to 78% of patients. Growth hormone deficiency can also cause abnormal strain echo, which is again a sensitive indicator for preclinical cardiac dysfunction. Growth hormone deficiency can increase inflammatory markers, homocysteine and CRP. Growth hormone deficiency can also decrease fibrinolysis, increasing the risk of thrombosis. So this was a nice study that looked at growth hormone deficiency causing increased abdominal fat, elevated total cholesterol, triglycerides, and LDL. And several studies have shown an increase in fasting insulin levels in growth hormone deficiency. Growth hormone deficiency can also cause endothelial dysfunction, decreased nitric oxide production, which can be also associated with an increased risk of atherosclerosis. So in summary, some individuals with Prader-Willi syndrome may be at higher risk for several cardiac disorders than the general population. Overall risk is not that much higher than in the general population, but seems to occur at a much younger age. That is that for coronary disease, it occurs in the late 20s, early 30s, rather than the 50s, 60s, and 70s in the non-Prader-Willi, but also in the registry, the PWS registry, we found an average age of 14 to 15 years for cardiac disease. This may be due to a combination of growth hormone deficiency, obesity, pulmonary hypertension, as well as underlying stress. At present, it's kind of difficult to assess the role of nectin deficiency, but again, we still need to do more work on that. There does not appear to be an increased risk of congenital heart disease in Prader-Willi syndrome compared to non-Prader-Willi patients. They do not seem to have a higher risk of type 2 diabetes or hyperlipidemia than the general obese population. And several studies, they actually showed that there may be a lower risk. Several studies showed altered autonomic nervous system in Prader-Willi syndrome with higher sympathetic and or lower parasympathetic stimulation, meaning that they're always in a state of stress. Obesity and growth hormone deficiency can also increase stress and inflammatory markers in the non-Prader-Willi population. Interesting is that a lot of the same risk factors for cardiac disease in Prader-Willi syndrome are also the risk factors for thrombosis. Coronary disease, although not common in Prader-Willi syndrome, but does seem to occur at a much younger age than the general population, even accounting for obesity. The individuals may not have the typical presentation, and awareness in the ED is important to at least have that on the differential. Basically, this presentation stresses the importance of keeping the individual at a healthy weight, treating underlying metabolic problems, treating apnea and hypopnea, and consider continuing growth hormone treatment onto adulthood, especially in individuals that may have other risk factors for coronary artery disease. This does not mean that growth hormone treatment is a treatment for obesity, but once you have them at a normal weight, the use of growth hormone may decrease their risk of heart disease going forward. I do have one case study, and again, I have to apologize. I do not see patients with Prader-Willi syndrome. This is one that was given to me. This was a 9-year-old female with Prader-Willi syndrome, had obesity and scoliosis. The echocardiogram at that time showed mild pulmonary hypertension with an RV systolic pressure of 37 millimeters of mercury. Due to the scoliosis, they did not feel to be qualified for growth hormone. They showed up again at 14 years of age, and a sleep study showed severe obstructive sleep apnea with an apnea-hypopnea index of 22.6. They were started on CPAP, but then lost to follow-up. They then presented at 17 years of age to the emergency room with severe obesity with a BMI of 52, acute respiratory failure, and desaturation to 65%. Echo showed moderate to severe pulmonary hypertension with a RV systolic pressure of 65 millimeters of mercury, dilated right ventricle, and moderately decreased function. She was intubated and eventually weaned to BiPAP. BiPAP was eventually titrated downwards to 24/14, and tadalafil, which is a medicine that we use to treat pulmonary hypertension, was started. A follow-up echo showed the RV pressures had dropped from 65 to 42 millimeters of mercury and significantly improved RV function. The patient continues to have a BMI of 47, but is tolerating BiPAP, and RV pressures have leveled out at 40 millimeters of mercury. Hi, Linda.
Yeah,
So
and
that's basically my study. This is some of the patients that I have treated when I do go to Kenya. These are all either pre-op or post-op patients for congenital heart disease. This is also the brand new heart center that we've been building over in Kenya. This is in rural Kenya, so this is an incredibly modern, up-to-date structure compared to almost all other hospitals in Kenya. This is will be opening up this next month, and I'll be able to be there. I'm going back to Kenya in October, and we'll be there during the grand opening. So with that,
thank you so much.
I will take off my screen sharing.
Yes, wonderful. And if anybody has any questions, feel free to type them into the chat box. And if not, we will say thank you so much to Dr. Loker for his presentation on cardiac issues with Prader-Willi syndrome.